Spotlight. So excited to be having this fantastic conversation with the experts that we have today. We're really happy that you were able to join us as well. Again, don't forget that this is our run up to the full conference, which is happening in May. And you can find it as usual at the NICE Network webpage, nicenet.ca. Again, finding out about the full conference. I also want to start off and thank off the top our sponsor for today, Rakuten Kobo, for their generous support and also making sure that everyone here is able to attend without barriers. A little catch up for the end. I'll tell you about our next speaker spotlight, which is going to be on April the 28th from 1 to 4. And it's going to be just extraordinary as well. It's going to feature award winning author Michelle Good in conversation with my husband, Michael Tamblin, the CEO of Rakuten Kobo. But today we're going to be talking about one of the biggest stories of the pandemic, which is, of course, long-term care. And the people that we have in front of us are going to be able to coalesce some of the experiences that they've had and folks that they've been working with. It's going to be enormously impactful, and it's nice because they're all also my friends. And with that great pleasure, I'm going to introduce to you first our speaker, Dr. Vivian Stamatopoulos. I've had a great pleasure of knowing Vivian for, I guess, I don't know, a very long time, Viv, at this point. And if you turned your television on in the course of the last 2 years, you saw Dr. Viv with an incredible following and an opportunity to really bring forward the voice of so many family members and friends and supporters of long-term care. She spoke bravely. She spoke with no holds back. She made me cheer more times than I can tell you. And believe me, she created a very loyal following coming from her own personal experiences and layering that together with her professional expertise in the field. She was really able to speak those words that we were all thinking, but somehow couldn't put together. Vivian holds an MA and a PhD, both in sociology from York University. And when I first got to know Vivian, she was really focused at that point on child and youth-based caregiving, which she still continues with her great expertise. But she really was able to grow that expertise into unpaid caregiving and, of course, in long-term care. She has done, I don't even know how many. She says 300 expert interviews. I think it's more like 2,000 expert interviews over the course. So I'm so excited to have, as she is known, Dr. Vivian, on our conversation today. The second person I'm going to be introducing to you is a wonderful, wonderful speaker in the area, particularly of health and healthcare, Dr. Charlene Chu. And Charlene is, and you would have known her from many different things, including conversations about long-term care from a nurse scientist point of view. She's dedicated her whole life, really, to thinking about how we can improve the care of older people. And if you're a researcher, you know that Dr. Shu is a rock star in her field. I don't even know how many manuscripts she has. I think 60 plus manuscripts, book chapters, and she's got patents as well. She leads interdisciplinary teams of researchers, really focusing on how integrated care can help older people when we so often want to keep them in silos. She did her original clinical practice as a nurse and her graduate studies in the area of long-term care and focus on geriatrics and practical barriers that older people are experiencing, as well as family and friends, have been the focus of her work. I'm so excited as well to say that she's just received the Connaught Innovation Award for the development of Nightingale.ai, and this is just an extraordinary achievement. It's a smartphone-based application increasing access to key rehabilitation after orthopedic surgery. And boy, if you've ever had anyone who's had a hip replacement, I can tell you that this is going to be just absolutely revolutionary. And the last person is Sam Peck, again, a dear friend. And Sam has been at the heart and the center of the pandemic with Family Councils Ontario. And what you don't see is that her tireless efforts to bring forward family of choice, family of kinship, and supporters of people in long-term care has been absolutely on those very front ends in the last 2 years. And she has, as I can tell you, very little in her support mechanisms behind her. So it is her leadership, her
Mhm.
vision, and her compassion that has really been able to muster and speak those experiences. She has been supporting thousands of family members and long-term care home staff to improve the work that they're doing, the experiences that they're having in long-term care. Family Councils Ontario is the only such organization in the country which helps to bring together and organizes the experiences of families and supporters in long-term care, and she does that extraordinarily well. She has honors from York University. She is a dedicated lifelong learner. And I tell you, every time I'm speaking with Sam, she's telling me she's finished another credentialing. I remember when she got her project management certificate from the University of Toronto. She's got a master's certificate in adult training and development. And she's now, just in case it wasn't enough, working on her voluntary sector management certificate at Ryerson. These women are the best of the best. They are the shining light of what we've been doing in long-term care. And it's with my great pleasure that I get to introduce Sam to you to take over the moderation of this fantastic event. Over to you, Sam.
Thank you so much for that very kind, warm introduction. It is now, without any further ado, my pleasure to turn it over to our speakers, Dr. Vivian Stamatopoulos and Dr. Charlene Chu. Take it away.
Hi, everyone. Thank you so much for joining us. Thank you to Laura for that wonderful introduction of Dr. Vivian and I, as well as Raza and the team for the introduction and for the invitation to speak today. We consider it quite a privilege to be here today. And of course, thank you to Sam Peck for moderating. I don't think we could have had a better moderator than someone from the Family Council of Ontario. So Vivian and I consider it, again, to just be a great privilege to come here today and share the stories of the essential family caregivers that we spoke to during the pandemic, who have been so deeply impacted by the pandemic and from their experience being away from their loved ones. And so before I get started, I really want to acknowledge their contribution to our research, and then I'll lead us through what we have to present today. Next slide, please. So for today, I'm going to just start off fairly quickly talking about the context. So first I want to talk about the visitations in long-term care, what they look like, and just sort of describe them so we are all aware of what we're talking about, although I'm sure many of you already know this. And so we'll speak quickly about that, and then we're going to talk about the three papers that Vivian and I have co-authored together. The first focusing in on the visitation experiences, the second being the technological barriers, because technology was put in as sort of a lifeline for family caregivers during this time. And then the third is really about trauma. So the tail end of the talk, Vivian will be discussing the aspects around trauma, and then we'll sort of step back 10,000 feet and discuss the implications of our work and sort of how this all converges together with advocacy efforts. And then I guess we'll end off sort of how we can look ahead. So we as a collective, we as a society, look ahead to prevent something like this from happening again. Next slide, please. So the COVID-19 pandemic has caused unparalleled devastation globally on individuals living in residential long-term care homes. And so this is true for not only residents, but also the family and staff who take care of them. We know that the responses in long-term care were about isolating older people to protect them from getting the COVID-19 virus, but also in this process eliminated basic freedoms with these sweeping visitation restrictions. And so these restrictions prevented essential family caregivers from seeing their loved ones in person, and also prevented them from experiencing small joys in life, like being able to get hugs. Next slide, please. And so what we saw is how these policies exacted harm. And ultimately, we ended up protecting a quantity of life over a quality of life. Next slide, please. And certainly all of this occurred with a backdrop of notorious neglect and abuse, and this was not unique to Ontario, but there was a staffing crisis, and you may be aware in the news that the Army was deployed in several nursing homes in order to stop the chaos that was happening in some of these homes. Next slide, please. Okay, so I'm going to go through some of the alternatives that were put into place for family caregivers as alternatives to in-person visits. And so as I go through these, I just ask you to imagine yourself being a family caregiver, trying to visit your loved one or your elderly parent or your spouse of 50 years living in long-term care. So first, we started off with window visits as depicted in this picture. If you were on the first floor, you were lucky enough to have window pane contact with your loved one. If you weren't on the first floor, then you saw your loved one often holding a sign outside to show that you were not alone. Of course, these were short-lived because in some areas in the United States, as well as in Ottawa, these window visits were banned. Next, we had outdoor visits. So eventually we were able to go outside in warmer weather. But of course, this meant that caregivers and sometimes residents were at the mercy of the elements. So we had rain, snow, etc. For example, in Ontario, this happened in July 2020. So that was really in the middle of a heat wave. And so we heard experiences of family caregivers having to visit their loved ones outdoors, physically distanced, wearing masks in the middle of a heat wave. Next slide, please. Then the next iteration of this was more group outdoor visits, where there are multiple families visiting at the same time outdoors. And then eventually we were able to get indoors in larger communal spaces, like in lobbies or in recreation rooms. And so these were still physically distanced, often like in this picture here, where there was a large 6-foot table in between or plexiglass. And so once vaccination rates were increased, so when they were about 95% for residents and 85% for staff, then at least people were able to see their loved ones again. And so this leads us into our current visitation now, where family members are able to visit their loved ones indoors, wearing masks as long as they're double vaccinated, although those mandates are being changed, and health screening in place, no more than 4 visits at a time. So what's important to note here is that I've sort of presented this as an evolution. But we know that this wasn't the case. Over the course of the pandemic, there was waxing and waning of these restrictions. There were times when there was an outbreak, when there was a wave, where family caregivers would go to see their loved ones, and in the case of an outbreak, then they would not be able to visit their loved ones the following day. So this is presented sort of as an evolution of the relaxation of these restrictions, but really it was a roller coaster, an emotional roller coaster for family caregivers. And so these residents and these family caregivers, they've been through a lot. And so this is why we really wanted to focus on them for this study. So the objectives of this study were to explore essential family caregivers' experiences with their loved ones in long-term care homes, as these policies and these visitation guidelines sort of waxed and waned during COVID-19. So within this, we looked at what was the role of technology to maintain their connection with loved ones, as well as was there and what was the extent of the trauma for these family caregivers. And so for our methods, we used a qualitative approach, semi-structured interviews. We audio recorded online focus groups that lasted about 90 minutes. And these were taken between January and March in 2021. We conducted 7 focus groups with a total of 30 essential family caregivers from Ontario and British Columbia. Our call was for all Canadians who would identify themselves as a family caregiver to somebody in long-term care, but our participants were only from Ontario and BC, and this is reflective of the provinces, English-speaking provinces, that had the highest mortality rates in long-term care. So for our analysis, we looked at the data, we used a thematic analysis with an inductive approach. And so this really allowed us to get familiar with the words, the stories, and look at patterns and concepts in order to be able to describe what they experienced. Next. So let's just describe who is participating in the study. So The majority were female, so 29 out of 30 people were female. The majority were also children, mostly daughters. They were 55 years or older. The majority were white or European. And it's important to note here that they were very, very involved in care. So 40% visit anywhere between 1 to 3 times, but 35% would visit 4 to 7 times a week, so almost every day. And 25% of our caregivers visited more than 7 times a week, so going to the nursing home and going more than once a day during the week. We also asked some basic demographic, in addition to these basic demographic informations, we also asked how happy they were with the care before the pandemic. And so what I want you to pay attention here is these last 2 lines about strongly disagree and disagree, where 8 out of 30 people, so that's about 25%, were unhappy. And then during the pandemic, this went up to 19 out of 30 people who were unhappy with the care. Next slide, please. So when we looked at the experiences of visitation, we found 6 different themes, and I'll go through each of these themes, but just as a sort of broad strokes, we categorize these themes into 3 different levels. So the first being more systemic, the second being more home level, and then the third being at an individual level. And it was really important to us during this research that we amplify the voices of the participants who often felt like they were not heard during the pandemic. And so you'll see in the next following slides when I describe the themes, it's really just the title of the theme and the quote, because I really want you to pay attention to the words of the participants and what they went through. Next slide, please. So our first system level theme is a significant lack of person-centered or family-centered ethos. And here we had essential family caregivers describe that they felt that the visitation policies from public health and from the homes basically ignored the needs of the residents, especially those that had severe physical and cognitive impairments who depend on these family caregivers for daily care, like eating, like toileting, like social contact. And so there were so many examples in these heartbreaking stories. This included stories about security guards being involved and monitoring whether or not family caregivers were maintaining a certain distance away from residents. There was the inability to really make any contact when that was the only thing that would provide care for their loved one. So a quote from one of our participants, "My mother hasn't been able to have physical contact until September. How is that even human? In terms of not having physical contact for months and months on end, we don't even treat prisoners this way. It's insane. It's absolutely insane." Next. Next was this lack of resources and staffing. So this was very apparent with the staffing crisis in long-term care throughout the pandemic. And so this is also a long-standing historical problem in this sector. But throughout the pandemic, there was a global crisis in staffing and a lack of the ability for staff and resources in order to meet the needs of these residents. And so family members recognized this difficult position staff were in, but then they also were fully aware of the lack of resources in these homes. So here we have a family caregiver who talked about the lack of technology and the lack of resources to be able to see their loved one. So in long-term care, they had 120 residents and 1 really crappy iPad. The owner refused to spend any money on anything more. We also had stories from participants who spoke about fundraising on their own time and donating their old equipment in order to facilitate some of these connections. Next slide, please. At a home level, we had inconsistent and poor communications between family and staff. And so this was a perceived disorganization within the long-term care homes themselves. So there was a constant lack of communication and follow-up, specifically around the well-being of loved ones, which was very concerning to family caregivers. And in addition to this, policies, as you can remember, were just constantly changing all the time. And so family members couldn't keep track of all of the different policies and protocols that were being put into place. Most importantly, these lack of communications really had a devastating consequence when we're talking about residents who are often at the end of life or often don't have as much time to live in these homes, and so family caregivers have lost time with their loved ones that they're not going to get back. So here we have a quote from one of our caregivers. When I reached the clinical director that day after 6 weeks to ask for permission to be at the bedside with my mother, and the administrator says to me, "Oh, we were cleared from the outbreak 2 weeks ago." But they never told me. Like, honestly, I think I will never forgive them for that. I'll never forgive them for that. I only had 4 visits with her before she died, and it was cruel. It's really brutal, on top of the pain that you're just feeling, being separated and worried constantly in anguish about how your loved one is. Next. Discord between the staff and the caregivers speaks to this active tension between these players. And so there was really a transition and a shift that family caregivers were often stuck wondering about. And that was going from the same team where they were both trying to focus on the betterment of the residents' quality of life to one that was more antagonistic, and when they were on opposite teams. And so here a family caregiver says, we were on the same side, and somewhere down the line, I became the enemy. So family caregivers really felt like they weren't being heard. They felt like they weren't being included in any of the decisions, and they were really feeling excluded by these broader policies as well as practices from the home. Next. So at a relationship level, when we looked at the family caregivers with their loved ones, what we heard over and over again was this shock from being locked out for so long, and when they finally saw their loved one, that there was a shock from reunification. And often the caregivers we spoke to talked about the physical and cognitive deterioration of their loved one. They talked about residents who were able to walk no longer being able to walk anymore, cognitive decline, the lack of communication, the decrease in their ability to communicate, rather. And so here there's a quote, my mother was skeletal. And then I got her into the room and I kind of took her sweater off, and I looked at her and there were ribs sticking out. I couldn't even fathom how much weight she had lost. And our final theme was around the relationship. And so we called this collateral damage, the relationship between the family caregiver and the resident as collateral damage. And so this really speaks to the harm that was experienced by both of these participants in these policies that were enacted. And families really describe this like screaming into the void, this being inhumane, and the harm that this caused the resident, especially residents that had dementia who were not able to fully understand why they couldn't see their loved one anymore. And so here's a quote. My mom was angry and hurt. She thought we chose to not come. She didn't understand why my brother stopped visiting her. She thought she did something wrong and she was angry with me. It was just awful. So I just want to pause here for a moment before we go on to the next findings. But just to let the gravity of some of these themes sink in a bit, because these stories were so moving, and frankly, they brought Vivian and I to tears several times during data collection. And just their feelings of not being heard, not being listened to, feeling helpless. It was very powerful. And we're hoping that our work can continue to sort of amplify their stories, but also give them voice as well. Next. So let's look at what was in place to help older adults and their family caregivers communicate and connect. So over the time when these restrictive policies were put into place, virtual visits using technology was really positioned as this viable alternative and this lifeline. And so this is a very idealistic view here of an older adult looking at an iPad, being able to communicate. But we really know, if you can click forward, that this is more about reflective of reality, where staff is likely involved to not only physically hold the screen, but also often repeat what was being said, and assistance was needed here. And so some of the themes that we found with regards to the impact of technology and the use of technology during this time was that there was a lack of technology and infrastructure to not only support the technology being used. So as we saw, there was a lack of iPads, but there was also, a lack of Wi-Fi, lack of tablets. So there were homes that were so antiquated where the Wi-Fi would not reach certain areas of the home, certain rooms did not have Wi-Fi. And so they were limited in that sense. Next theme, please. And then also technologies required a staff presence, and this applied additional pressure on staff that were already overworked, often working short-staffed. And also many of the technologies themselves were not adaptable to the residents' physical and cognitive impairments during the visits. So one of our participants spoke here about, my mom lost the use of her hands entirely or sometime over the summer. So she was now rendered quadriplegic. We did FaceTime, but she couldn't see, she couldn't hear. And so there was a real theme here of unmet resident needs. And there was really this lack of consideration for the physical and cognitive impairment during these virtual visits. So I'll hand it over to Vivian, but my job here was sort of to explain the context and the background around the experiences of these family caregivers, and then how they basically, collectively led to additional trauma, which Vivian will talk about next.
Thank you, Charlene. Well, I mean, this was really important for me to really hit home, this notion of trauma. And it's been very clear, certainly throughout my advocacy, but, only reiterated through our research, that these families were traumatized by what happened. And trauma is not a new concept for this pandemic. We have experts who have been writing about how the COVID-19 pandemic can be viewed as a cause of collective trauma, a cataclysmic event, a crisis of meaning experienced by a given group of individuals. So in this case, we felt pretty confident that we were going to find that essential caregivers fit into this group of traumatized individuals. And of course, while the experiences and responses to COVID-19 are heterogeneous, similarities can be observed in the psychosocial consequences, but they disproportionately impact marginalized communities. And, essential family caregivers are predominantly women who are known to be vulnerable to the act of providing care, being empathetic, and then being exposed to the stress resulting from this caring role. So for us, it was really important to really, document the collective traumatic experiences of these individuals during COVID-19, because you would hear a lot about the resident experience, you would hear a lot about the worker experience, but you didn't quite hear as much about the essential family caregiver experience. Next slide, please. So the four themes that we have for trauma, the first one being, a clear trauma from being separated for a prolonged period of time from your loved ones. I mean, anyone can imagine what this would feel like. And this is, the quote I have here is a wife talking about being separated from her husband, and as she said, imagine being locked away from your husband, never to see your husband. Locked away from your parent is horrible, but I was locked away from my husband, my other half. This is half of my life, and they've stolen it. It was just undeniable that this restricted access to residents during COVID-19 was, one of the hardest things that these participants had to endure. It created significant fear and anxiety among these participants, our essential caregivers. They felt like they lost time, like time was stolen from them. And it was. There was a persistent presence of, long-term negative experiences and emotions. You would hear things like, we've lost an entire year, we can't get this back. You would hear a lot of accounts of how this experience just completely damaged the relationship with their loved ones, many of which were suffering from, dementia or Alzheimer's, and frankly, were confused and thought at times that their absence was deliberate. And obviously it wasn't, but, there's no one there to keep explaining to individuals who might have this, cognitive decline, what is continuously happening. So this was so stressful for these families, knowing that their loved ones often thought that they just chose not to visit and chose to effectively abandon them in these facilities, and nothing could be further from the truth. But then, what was also traumatic was when we started to see visitation increase in its various iterations, which were all problematic. And I remember going through, doing media about the problems with each form of visitation, from windows to the distanced outdoors to the distanced indoors, until we finally got the semblance of what we have now, which is the traditional caring role, bedside, where you can touch, you can be close to the individual, typical caring role. But the nature of these always ever changing and often nonsensical visitation styles that often had a very heavy security impact. I remember at one point in Ontario, this government earmarked $42 million for security just for long-term care. So I want to try to really hit home how difficult this was, having this almost like prison style incarceration style visitation, where you couldn't touch your loved one, you couldn't get within 6 feet, or else a security guard would run and threaten to kick you out. I mean, this is what these families were dealing with. You can imagine the trauma of seeing your loved one and not being able to touch them when they're begging for you to just come close and hug them and touch them. The level of frustration and upset from dealing with that over a prolonged period of time and being thrown scraps from which you could, have some sort of limited access to your loved ones was just a very clear form of trauma that lives with these individuals, these participants. And you could really see in their accounts in these focus groups just how upset they were. And they would tell us, after visits, they would often end up just crying in the parking lot of these facilities. They couldn't drive. They had to just compose themselves because these visitations were so upsetting, not only to them, but to their loved ones, who wanted them to be able to come inside and hug them and be with them. And having to see how it impacted their loved ones caused this form of, almost codependent trauma, where they just felt so hopeless and so powerless. And this was all from the prolonged separation. The next theme is this trauma from very clear, uncompassionate interactions with the long-term care staff and administrators. So one quote as an example here, my mom started to really deteriorate. I tried calling the long-term care director one more time. She picks up. It was very testy. She skirts my questions. And before we go any further, I asked the clinical director, why have I not heard from you for 6 weeks, or from an associate? And the clinical director totally glossed over my questions and says basically, we were busy and your, opinion is derriere. So there was a very clear and overwhelming pattern of these participants or essential caregivers feeling like the staff and the administration were just uncompassionate or unempathetic. You would hear this in a variety of forms of just fractured, incomplete, or dismissive communication with the long-term care homes. Often it would take repeated attempts to try to get anyone on the telephone. You'd often be met with busy signals or voicemails. And when you did get through, and you would try to express some sort of suggestions or concern or ideas, or provide some sort of, try to even negotiate entry to whatever end, you were often met with hostility and apathy. And we would hear a lot of those accounts. Another issue which was glaring was the scheduling of these visits. Because keep in mind, for the first 6 months, they were largely locked out. They maybe had a peppering of window visits and outdoor visits. But when they could actually get inside, when in Ontario, for example, this didn't happen in BC until a full year, but in Ontario, when we finally got that essential visitor directive in September, before then, it was a nightmare just trying to schedule these visits. And it's all these family members had. So you can imagine it's something they looked forward to with everything in them, because all they were doing was worrying about how their loved one was in their absence. So they would, keep in mind, a lot of these women, these working women, have responsibilities. And often these homes would only give them, appointments during like the 9 to 5, Monday to Friday window. So a lot of these individuals had to, take time off work, had to really structure their lives around these visits. And then you would hear a lot of stories about how they just, they'd show up to the visit and all of a sudden, your mom's not up for it, or we had to take her for a shower. It's running a half an hour behind, or it's canceled altogether. Something happened. And they wouldn't give these family members notice. So that created, just an added layer of ongoing trauma when they would be looking forward to these events and these visitations and plan accordingly. And then many times. They'd be canceled, no notice, and this was the process. And then constantly trying to, make it work and to see their loved one was just, it never ended. It was rife with problems, lacking in communication. And quite often it was just very rigid, and it didn't make sense to really anyone. And that created an excess of, quite frankly, frustration and anger among these family members who were like, well, why can't I come at night? Why can't I come at dinner time? Why can't I come after work? Like, why do I have to take off, a day off or a morning off? Like, it just didn't make sense. And it just felt like it was, it really made the lives of these essential caregivers even more difficult. You would also hear how they felt really ignored and disrespected. Quite often, these family members, these essential caregivers, felt like they were being deliberately kept out of these homes. And to them, it was because they didn't want what they believed is that the homes didn't want them to see the conditions within the homes, how terrible the staffing was, just how few people were actually there to provide care in their absence. And one individual said it really succinctly that, these long-term care homes made a decision to focus on liability first and humanity second. And that really stood out. That was a theme. And you would hear essential family caregivers describe these long-term care homes and the government as playing God, right? That which was a powerful metaphor depicting the hierarchical differences between these, the government who was making these rules and then the long-term care homes who was enforcing these rules. But it wasn't a benevolent God. Keep in mind, we would hear from families repeatedly that if they ever raised concerns, which, as you can imagine, based on everything you saw in the media, which was accurate, there were many concerns to be had by these family members. When they would raise these concerns and try to, provide suggestions and just indicate that something isn't right here, they were often chided or treated as a squeaky wheel, a nuisance. Worse yet, some individuals would tell us that they were penalized, and then by speaking up and by actually, being more forceful and trying to advocate for their loved one in care, it would then lead to, accidental cancellations of your visitation booking, or, oops, we missed your phone call, more limited communication. So you would definitely hear accounts where they felt like they were being penalized for speaking up, which is a fear. And it was clear that there was an us versus them mentality, which was very frustrating for these individuals, because to them, they were used to having a more collegial, collaborative relationship pre-pandemic. And now all of a sudden they felt like they were the enemy. They were othered. They were treated as, they're the vector of transmission. They're the ones that are going to bring in this virus, or they're the ones that are going to leak to the media what's going on inside these homes. They felt like they were the enemy. And certainly they were given quite significant reasons to feel like that. The next theme, number 3 on the next slide, is the trauma from the inability to provide that hands-on care. And this one was really important. Keep in mind, many essential caregivers are not merely the powers of attorney or the substitute decision makers, but they would tell us expressly they are their eyes and ears. I mean, these individuals felt personally responsible for advocating and for making sure these residents were safe and taken care of properly. And they have good reason to do that, given the known, issues within the sector that predate COVID-19, but were just, amplified because of all of the issues with staffing shortages, et cetera, that happened with COVID. So we would hear cases of, these participants just not being able to sleep, just fraught with anxiety and worry about what was happening in their absence, knowing, well, who's going to be there to help feed mom? Who's going to be there to make sure dad takes his pills, and who are they going to get his pills? Is he going to get changed? Is someone going to help him so he doesn't fall out of bed if he goes to the washroom? I mean, these concerns were just palpable, and you knew that they had reason to be concerned. And obviously, you could just see the accounts of how much this upset these family members. I mean, we were all crying in these focus groups. I mean, I've never been part of such emotionally, just heartfelt experiences where you could feel how hard it was for these family members and how clearly traumatized they still are from what happened, that they are still living with these experiences. And one particular example here, and this is textbook. So a lot of these essential caregivers, keep in mind, these are individuals, often a handful of individuals who are there often, 5 to 7 times a week in these facilities, providing upwards of 30 hours of unpaid care. I mean, these are essentially, you lost what is tantamount to a part-time, if not full-time, unpaid worker when you lock these families out. So they knew that there was a significant consequence of their absence. And one prime example is, a lot of family members go in during meal times because there are known issues with not providing the workers enough time to actually do the tasks required. And workers will tell you this too. There's just not enough time to do everything in a given day. And this is why workers burn out and leave. So feeding is one of these issues. Obviously, older adults take more time to eat, to chew, to swallow. So you really have to be patient when you're feeding them. And one particular daughter had mentioned and knew that her mother had a choking hazard and had a tendency of aspirating. So she begged at the start of the pandemic, please let me just come at meal times. I'll do whatever it takes. I'll wear whatever PPE you want. Let me come in because I'm worried about my mother choking. And lo and behold, as anticipated and as predicted, one day, and this is the quote I have here. So then in June, one morning at breakfast, she choked. They had to perform CPR and suction, and I was called and I was allowed a 1-hour compassionate visit. And then I was told my hour was over. I was back to window visits the next day, and the staff were crying. They were in tears and said, we almost lost her. I mean, her mother almost died because of something that would have been prevented had she been allowed in. And this was a very clear pattern within our research where these participants knew the consequences of their absence. And when they started to be reignited or, have that access slowly introduced, the things that we would hear, the rapid cognitive decline, speech loss, forgetting their loved ones altogether, unexplained injuries or infections that were clearly preventable had the loved ones been in the homes. Weight loss was such a damning finding. I mean, literally the word skeletal was being used among multiple participants. We're talking upwards of, 20, 30-pound losses in a few months of their absence because they just weren't eating. There weren't enough staff to feed these residents. And if they had time, they couldn't finish their meals. They just did not have enough time. They were stretched so thin on a skeletal, no pun intended, staffing level, given all the losses and people leaving and the workers getting sick themselves. So this was really upsetting. I can't hit home enough how being unable to fulfill their caring roles, which they knew were integral to the safety and well-being of these residents, left them with immense feelings of guilt and disappointment and anger towards these long-term care homes for the lack of recognition for how important their caring role was, and understandably so. The final theme 4, is this trauma from experiencing prolonged powerlessness and helplessness. I mean, keep in mind, within the context of this lockdown, essential family caregivers had to rely exclusively on the long-term care homes to keep their loved ones safe and well, without any access, without any aid or oversight, which you can imagine left them feeling incredibly powerless, almost hopeless. They were also aware, and we were all aware, of the very newfound and potent power imbalance between themselves and the owner-operators and the government during COVID-19. And the quote I have here is really indicative of how these family members felt. So if you want to click the link there, we got that quote will come up. You're at the mercy of someone who holds all the power. And when you can see your beloved family member next and you want to complain, but it might get worse, or you might have different rules than somebody else, or maybe grandma's going to suffer if you say something. So you just keep your mouth shut and wait for the next visit. This kind of forced and learned helplessness out of fear was something we heard repeatedly. And keep in mind, many factors contributed to this feeling of hopelessness and powerlessness. Not only the long-term care sector's sudden ability to just create policies that blatantly violated residents' rights. I mean, remember, residents have rights in Ontario. They have a Bill of Rights. There's, I think, 26 rights that they are supposed to have ingrained, every single resident, violated with impunity. Then there was the paternalistic oversight of essential family caregivers, while at the same time inadequately monitoring the staff who were known and shown to be the source, the majority source of the COVID-19 outbreaks. Yet it was the essential family caregivers that were treated like they were the primary vectors of viral transmission, even though they were locked out of the home. So it clearly had nothing to do with them. The irony. There was the inconsistent application of provincial guidelines between the homes. Some homes would just make up their own rules. Some homes, would do things differently. And this was incredibly stressful to figure out, what's the policy here? What's going on? There was obviously this fear of retaliation if you speak up. The punitive oversight of the visits. And I'd alluded to this before. I mean, when you have security guards that were hired by these facilities, specifically during COVID, aided and abetted by a government who was funding millions of dollars to hire, to effectively enforce a police state in long-term care, which is the worst idea I can ever imagine. And I still can't wrap my head around how they thought this would be smart. But nevertheless, it happened. And just to limit their contact, make sure they don't touch, don't get too close. Like, can you even imagine if this was you being kept away and treated like this from your mother, your husband, your wife, your grandmother, your grandfather? I mean, it's just horrifying. And underpinning the sense of powerlessness and hopelessness was indeed the government and the long-term care homes categorization, the very offensive categorization of family members somehow as non-essential visitors. And this happened, for upwards of a year in BC, 6 months in Ontario, until we actually, accepted that family member are essential, which is ludicrous that we even have to create designations of family members as essential. And the fact that they were created or deemed non-essential is something I could really vent about for a long time. And I have vented quite publicly about this, but still irks me to this day. And clearly, as you can imagine, the participants felt intense frustration and anger with being deemed non-essential. I mean, this is the most essential person in their life. How dare you? How dare you say that they are non-essential and you can just keep them out? Just lock them out for months at a time, no problem. I mean, these family members, these participants would have done anything. And they would tell us. When one participant said, I would have bathed in sanitizer, I would have injected myself with bleach. They were being facetious, but this is the point. They would have done anything. And keep in mind, they jumped through every single hoop you put in front of them. Most glaring being the discriminatory testing policy that was levied against essential family caregivers, and nobody else, no other group had to deal with the testing that these essential family caregivers of loved ones in long-term care had to deal with. Some of our participants had upwards of 50 PCR tests in an 8-month period, 50 PCR tests. We didn't even have this testing policy for hospital workers, for the long-term care staff. But yet we were literally asking them to test more than any other group. And they did whatever it took. And keep in mind, this is at a time when there were long wait times. PCR testing was far and few between. They were at select locations. So then these essential family caregivers had to book around, had to take time off work to make sure that they'd get these visitations and get these COVID tests so that they could, provide the negative attestation to the home so that they could get entry. So, I mean, it was just constant, hoop that they'd have to jump through. The next slide, discussion. Well, I think it clearly highlights, I hope it clearly highlights that our research showed that, this entire pandemic experience for these participants, these essential family caregivers, was just beyond emotionally charged and negative. They were confronted with just frequently changing, often inane visitation policies and rules, discriminatory testing policies. They did anything that was asked of them. And I think what was most upsetting was that what was previously a collaborative and collegial relationship with staff before the pandemic was suddenly replaced with one that was just rife with tension and opposition, where they were effectively othered and treated like the enemy, almost overnight. And, this raises not insignificant questions about how do we repair these damaged relationships, because they are very damaged. And how do we go back to actually prioritizing the residents post-COVID-19? Next slide. Keep going. There we go. So in terms of, implications here, sorry, I jumped over a slide. That's my fault, but I'm going to keep talking. Don't worry about it. Participants expressed significant anxiety towards, obviously, these damaged relationships. And what was clear is that there was this very severe pandemic pattern of othering these essential family caregivers as non-essential. And at the end of the day, right, it's forced us all to look back and say, well, we've learned some uncomfortable truths about long-term care because of this entire pandemic, mainly that, the systems and policy are based on ageist traditions, self-interest, and revenue generation, not on the patient's needs and health. Long-term care homes and the governments were, they were afforded full power. They did whatever they wanted. And the essential family caregivers, these loved ones of these residents, were effectively sidelined. And they felt devalued, underappreciated. They frankly felt abandoned and unrecognized by the broader healthcare system, which is a really damaging reality. And of course, you can't get away from the fact that certainly in my mind, and I hope, when you start reading the very lengthy papers that we have coming out, we're trying to, summarize it here in short form. But this group is definitely a group that experienced a source of collective trauma. This trauma has certainly influenced a new generation of potential long-term care residents who are terrified of entering long-term care like never before. I mean, we would hear participants tell us, I'd rather die. Drive me off a cliff and, go through MAID. I do not want to go into long-term care after living this nightmare. And governments in long-term care homes really need to think long and hard about what they're going to do to repair this harm. And when it comes to the future of long-term care, I mean, particularly in the sense of the essential family caregiver experience, I mean, one of the things that was glaring was, we have Residents' Bill of Rights, and I talked about that in various iterations in the different provinces and territories, but they were blanketly denied. They were just trampled all over with impunity, which is, well, then what's the point of having these bills of rights? They're just paperwork to line the offices of operators and frankly elected officials if you're not actually going to do anything about them or maintain them. So one of the main things that, in my advocacy, what I started to do was I teamed up with MPP Lisa Gretzky and then other essential family caregivers pictured in that photo above to try to legislate caregiver rights, and not just for long-term care, but worker, any congregate care living facility, because this was happening for, parents of children in group homes with disabilities and adults with disabilities. It was happening in hospitals. So this was happening across all congregate care facilities in various iterations. So we all tried to team up to, get this bill tabled to really fight for it. And unfortunately, and the irony is that because of this bill and the press that came around it, the United Kingdom paid attention and actually reached out to Lisa Gretzky, and she helped them develop, their own bills. And although our bill never made it into law in Ontario, which was Bill 203, the More Than a Visitor Act, it just literally passed in Scotland. So they have Anne's Law now, which is an iteration of our Bill 203. But the irony is our government, our premier, just did not find it fitting to pass that into law, even though it passed, both readings and just needed to go through final assent to become law. So that is obviously something, if I had the power here, I would legislate rights for these essential family caregivers, first and foremost, to never be separated, to never have this prolonged kind of separation ever again. And then the role of family councils, which is really important, which is, I hope Sam talks about this too. Family councils are self-led, self-determining groups of families and friends of residents who actively and whose main goal is to try to improve the quality of life in these homes and to really affect the procedures and policies in long-term care. So strengthening their capacity to engage in long-term care decision-making is super important going forward. And indeed in Ontario, they actually did when the next minister came in. So we've gone through several ministers now, we're on to our third. But when Minister Phillips came in, he provided more money to family councils in Ontario. Of course, this is just Ontario. So it's not to say that this is blanket across Canada, but this is certainly in the right area. I know that I worked with some of the for-profit family councils, so particularly some of the Sienna family councils, and they were very successful in going head-to-head with the operators and getting things done. So getting things like, for example, air conditioning in these homes when we dealt with two, record-breaking, heat wave summers, and that, a lot of these homes, particularly the older ones, for-profit ones, often didn't have air conditioning. So they were really instrumental in fighting for change for their residents. So I've seen the success that can come from really, well-organized and empowered family councils. And then this notion of undoing the damage. I mean, I have a quote there. It's really long, so I'm not going to read it. But this is an excerpt from the Long-Term Care Commission in Ontario. We have the Long-Term Care Commission that looked into this nightmare that happened in Ontario long-term care homes. In Quebec, there was a coroner's inquiry. So what we found in Ontario, and this was an excerpt of their final report, the commissioners made it very clear that, that these staff and these residents were traumatized what happened. And they actually suggested in this quote I have there that the long-term care homes, frankly, need to provide counseling assistance to these staff and these residents due to the fact that many continue to be traumatized as a result of the lockdown experience and will require ongoing counseling and support. Of course, I think we all know this now, certainly from our research, know that essential family caregivers need to be added into this group of individuals who were clearly traumatized in this long-term care experience and should also receive any theoretical counseling that frankly, I haven't seen any of this happen by any long-term care providers to date, even though we clearly need this kind of support for what happened, the very clear trauma that is well acknowledged. So, you know, these are key areas. The other main area, moving on to the next slide, is this notion of national standards. So obviously, Sam, go to the next slide, please. Okay, so long-term care standards. So about, go back. There we go. Okay, so about a year into the advocacy, and my advocacy, when I was the first thing I did in my advocacy was try to get access for these family members to get into the facility. That was the main thing I was focused on. And at least in Ontario, when we got that access, my next awareness was, okay, we need to look at this, you know, higher level. We need national standards. This is clear. It's not just Ontario. This is happening across Canada. So, you know, me and some family members, long-term care family members, and a long-term care lawyer created just a voluntary, you know, advocacy group, Canadians for Long-Term Care Standards. And we had a campaign over the next year, really pushing to raise the discussion around national standards. We had town halls with experts, family members, workers across Canada. We met with the federal government. We met with the Prime Minister's office. I have a video there where I had the opportunity to ask Justin Trudeau, our Prime Minister, directly, what is happening with long-term care standards? We need national standards. And I got a really nice, you know, long answer about how we're going to do this. And we got an announcement, you know, a few months later that indeed they were setting aside $9 billion now to address the damaging, dangerous shortfalls of long-term care across Canada, not just Ontario. And that they were going to be working to create national standards and to push for things like a $25 minimum PSW hourly rate. So, you know, the promise and the pitfalls. The promise, obviously, the announcement has been made. They had put in charge groups to actually come up with these standards. So the HSO, it was the Health Standards Organization, partnered with the Canadian Standards Association to work together to form two committees that would look at both care services and then the technical committee. And I know we actually have the technical committee founder presenting during this conference too, so you should check out his talk. But that said, some of the pitfalls, and I've also been very open about what I think some of these pitfalls are. So first of all, you know, there is a current iteration of, you know, Health Standards Organization national standards, but they're in the form and they're already in use in the form of accreditation. And keep in mind, before the pandemic, 58% of all long-term care homes across Canada were indeed accredited. But I mean, what good did that do? Because look at what happened and look at the ongoing problems. So you know, number one, accreditation isn't working and hasn't been working. So I have a problem with that route. I wanted legislation. And then as it's being pitched right now, there is no guarantee that provinces even have to play ball and enforce the national standards that will be formulated hopefully soon. We have the committees that have put out reports, but we haven't actually seen national standards materialize yet. And furthermore, within the care services group, I was hoping to see some sort of wording about never separating residents from their loved ones ever again. And that was not in those draft standards from that one committee focusing on the care services. So, but again, They have yet to materialize. So the hope is that they will create a standard, in my opinion, a legislated, a law saying you can never separate these people ever again. And then the next slide, the for-profit elephant in the room, and not just in terms of ownership, but also management, the twin elephants in the room, so to speak. There has been story after story during this pandemic of just how poorly many for-profit homes operated. I mean, literally, we have, Sam's going to keep clicking. We had national campaigns, union campaigns fighting to end for-profit long-term care. We had, a campaign to make Rivera public. We had the federal NDP calling to end for-profit long-term care altogether. I mean, we had story after story, and we had the evidence of just how poorly they performed. If you're going to look at COVID-19 statistics, COVID-19 mortality, I mean, they had in Ontario alone, we had the Toronto Star put out most recent data, which show that, even after accounting for facility design and community transmission, the for-profit homes still had far more deaths. I mean, this pattern held even after omitting the 10 homes with the greatest death rates. And I'm sure you've heard of some of these, the Orchard Villas, the Roberta Place, the Tender Cares. I mean, they even eliminated those, and the for-profits still had far more deaths. I'm talking a significant difference. And I've been very, upfront about how I feel about this. And how we need to end for-profit long-term care. And I have a short clip on the next slide of me hitting home why I'm so adamant about this, that I think we can show this. It's just under a minute. Assuming the volume works, so you can just see me yelling. It's getting there, it's getting there. Okay, we might not have the volume here, and that's okay. You can watch this. I mean, you can find, God knows, too many annoying myself. I annoy myself with all the interviews I've done, so you can see them on my Twitter if you want to find them. But, I've hit home, and the main point of that video was just, I mean, nobody wins in the for-profit model. The residents don't win. The workers don't win. The family caregivers didn't win. Really, the only people that win, and it's because of the fiduciary responsibility of these for-profit entities to create profit. The only people that really win and are really motivated to win are indeed the shareholders and the CEOs. So, I've been very clear that I don't think we're ever going to get to the kinds of change and the kinds of progress we need while maintaining this dangerous status quo. And indeed, when we go to the next slide, you see that we're learning nothing from what happened. Unfortunately, even though, for example, the federal NDP wanted and put a motion up to end for-profit care, the PCs and the Liberal government themselves, being Trudeau, which really disappointed me, voted that down. And you'd think this is, after everything that happened, this is the moment to end for-profit long-term care. Didn't happen. And, what we're seeing instead is that we're actually seeing some of the worst for-profit bad actors being given significant generational licenses and money to keep doing what they're doing. And recently, over the past month alone, March 1st and March 31st, both Rivera and Chartwell, these are two of the biggest long-term care providers, for-profit long-term care providers, are now selling off, their long-term care portfolios and focusing on retirement housing, which is more profitable. Don't get me going there. And they're selling it to other private equity firms and other for-profit entities. I mean, this would be the opportunity. If they want to get out of Dodge, fine, don't let the door hit you on your way out. At least make a guarantee to go to the nonprofit sector. We are losing these just remarkable opportunities to move towards progress, to listen to the evidence that predates the pandemic and actually do something right here and move to nonprofit, ideally public delivery. And we're not seeing that, sadly. There is a little bit of hope, though, on the next slide. It doesn't have to be this way. Saskatchewan got it right. They saw how extended care handled long-term care in their province, and they said, forget it, we're done with you. We are ending our relationship with you. We are taking over these homes into the public sector under the authority of the Saskatchewan Health Authority, and we are doing this as, public long-term care. I mean, this is what we should be doing. Why does Saskatchewan have the brain power to do this? And yet the provinces hit the worst, Ontario, I mean, BC, they're not doing it. So it just doesn't make any sense. It's just such a missed opportunity, particularly for Revera, because Revera was owned by the federal government, the public sector investment board. And there was a whole public campaign, make Revera public. And this could have happened. Our prime minister could have made this happen. And instead, they're letting the sale go through to more for-profit and private equity owners. And it spells disaster to me. And I'm really worried about the future of our long-term care, frankly. And this going into, the next slide, which is just my final thoughts, because I know I'm probably hitting my time here. I'm not in a good mindset when it comes to, being hopeful and optimistic for the long-term care situation. Basically, because of what I had just shown you, we're going the opposite way that we should be going in. We're not learning from the mistakes. We're actually replicating the dangerous status quo that got us into this situation we're in right now. So, and I hate to be, pessimistic and glass, half empty here, but I'm also a realist. And my advice to families right now is you really got to plan ahead and really learn to protect yourselves, because as I see it right now, and based on everything that I've dealt with, both in our research, but also in my advocacy, it feels like we're on our own and things aren't getting better. And I'm really worried about, our future generation of long-term care residents, particularly because given changing, sociodemographic characteristics of our population, more unmarried, divorced, single individuals that are going to age into adulthood, often without children, less children. There's not going to be people around to care for you. And you're going to need long-term care now in our future more than ever before. And I don't think people realize this. And I've been trying to warn our younger populations and even us now in our 40s and our 50s, like you're going to really want to think long and hard. You're going to want to start putting money aside. You're going to want to start trying to prepare for home care if you can have it. But at the same time, the inevitability is that many individuals, even if they fight for staying at home as long as possible, like my family did, like most families in our study and that you hear across the board, they have tried to stay at home as long as possible, but it gets to the point, and we often find this in the last year or two of life, where the care needs are so extensive and the kinds of technology and the kinds of equipment you need are just too expensive and not feasible in a home environment. Long-term care becomes the only option. It behooves us all to really fight right now to do the things that we need to do to prepare for what is going to be our future. Like it or not, people say, I'm never going to end up in long-term care until it happens, right? You should plan to end up in long-term care at some point. And everyone should start really hitting home with their elected officials to do things like end for profit, to create national standards, to have penalties with teeth that actually get these bad actors out of this system, and to really protect who we are hoping and supposed to protect in these facilities, the residents, right? Because what I'm seeing right now is a lot of regulatory capture and a lot of conflicts of interest and dangerous relationships between a lot of people in the long-term care sector with people in power. And I'm not seeing the kinds of changes we need or that we could replicate, changes that we see in Nordic countries where they actually get it right. And I'm not going to keep rambling because I know I'm out of time here, but we can talk about this in the Q&A, I imagine. But so sorry to end on a terrible note. And thank you so much for listening to us. And then there's just some slides on our funding sources. We really just thank you for listening. And we really hope that these experiences of these family members and these essential caregivers, really resonates with people, because it was just a really terrible, terrible 2 years and counting for these family members.
Doctors Chu and Stamatopoulos, thank you so much for this passionate, enlightening discussion, or your presentation. I know that I'm sure we've all got questions of you to discuss. But in the meantime, we are going to take a quick break, about a 5-minute break. During that time, I encourage you who are watching, tuning in, take a quick stretch, perhaps grab a glass of water, but really think about what you want to ask of today's presenters, Dr. Stamatopoulos and Dr. Chu. We will be back in 5 minutes, so get those brains going. Hello again and welcome back. Another big thank you to our presenters, Dr. Chu and Stamatopoulos, and a big thank you to all of our esteemed guests, really you watching this from the comfort of your home or other place. We hope you're well. Today, we are going to dive into the questions that you've been asking in our YouTube chat. So we've got a lot of really great things to discuss. So let's get started. Good question to start off with actually is, Drs. Chu and Stamatopoulos, there have been discussions about the wording, the terminology, designated care partner, essential family caregiver, using the term essential or not. What's your take on the wording there? Essential, is that deeming that others aren't essential, or how do you respond to that?
Go ahead. I always had problems with it just from the fact that obviously family members and the closest loved ones of these residents were deemed non-essential. It just made no sense to me. And then we had to fight for that designation. And then even when we got the designation, you would see it was constantly changing. Some people would be given essential status and then it would be taken away. And then it was just completely arbitrary. And it seemed to be completely at the whim of, frankly, the government and then the long-term care providers. And, obviously it was useful in the Ontario context to get family members and loved ones designated as essential and to really fight for that policy that came into effect on September 2nd, which really made Ontario leading in the way of access across Canada. But again, it's arbitrary. It was ever changing, and it felt offensive that there even had to be a fight for family members to be called essential when clearly are they not the most essential people? It was always mind blowing to me. I'm sure Charlene will have a more eloquent answer than the one that evokes rage from me. But yeah. That's how I would approach it. I mean,
oh my goodness. I absolutely echo Vivian's sentiment. To some extent, it is arbitrary. I don't think it's within, the purpose of our research to say some people were essential and other caregivers were not essential. That's absolutely not what we were saying. But certainly from our perspective, from what we've seen in the literature, what the stories were, the duties that our participants, the amount of care that they provided alongside, not just only their visits multiple times a day for some of our participants, but they also told us the things that they did. And so they did everything from feeding, grooming, bathing, taking them to the washroom, communicating with them, having them communicate with others outside of the home. Everything that they did was vital to their quality of life.
Great, thanks. I know that it's, I'm sure, an ongoing discussion about terminology and what, really what's the, a best or a leading approach for designating those caregivers. But with regards to caregiver rights, the role, how do you see the rights of essential family caregivers tied to the Residents' Bill of Rights? Or you, Vivian, or Dr. Stamatopoulos, you talked about the rights of essential caregivers. Is what's in the Residents' Bill of Rights enough?
No, it's not. And the Residents' Bill of Rights really just looked at the residents' rights to access their loved ones. And the bigger, and those weren't actual laws. These were, Bill of Rights in, the long-term care homes legislation, but, these were fancy little things. They would obviously, post in elevators of these facilities, and most people didn't even recognize existed, if we're going to be, realistic here. And they were just, the other troubling part is that what we saw with COVID is that the government just unilaterally trampled these rights, which part of me says, and then the rational side of you goes, well, why are you fighting to have caregiver rights if they're just going to trample over those too? And there's a very real, fact that could happen too, but we had to try. We wanted to at least get legal legislated rights based, squarely on what we learned from this pandemic. And there's, my fear now is that, have we learned anything from this? What happens during the next pandemic? We're just going to, my gut is that we're just going to do the exact same thing over again. And these poor, future generations of older adults and persons with disabilities are just going to live this kind of incarceration yet again, because I don't see any real change or even real acknowledgement of the harm done. We had media story after media story, but to this day, where are the apologies? Where's the acknowledgement from the larger sector level, our elected officials, for just how wrong this was, like just how much of a violation of humanity this was to do this? And I don't see any real awareness of just how disgusting this was. I mean, of course, the family members, the residents, the public was horrified by what happened. Horrified. I mean, I think it goes without saying that the long-term care, this was the story of COVID-19. This was the biggest national shame. And added to the fact that we did worse than other countries. We were one of the worst countries in terms of COVID-19 death rates in these facilities. And yet I don't see some sort of responsibility actually being taken, and awareness of just how badly we wronged these families and these residents.
Following up the idea of doing better and needing to, so that the next time something happens, whether it's limited to a home and influenza outbreak or something more on the scale of the sector as a whole, there's a good question is, will you be making comparisons with homes that, quote, got it right? And this person's asking, saying, I know of one home where the staff is like loving family, zero resident COVID deaths, and thus have some lessons that can be learned and applied in other settings. Yeah.
I mean, for sure. I mean, I don't know, Charlene, do you want to go? Because I automatically go to ramble. Do you want to go first?
So that's a great question. I'm sorry, I can't see the questions on my screen. So thanks, Sam, for going over them. So I think that, one of the papers that I wrote over the course of the pandemic was one where we compared 6 different countries. So we compared Canada, Brazil, the United States, Switzerland, and Japan. And we looked at sort of these dominant themes and what was done first. And the most common thing that we found across all of these countries, all 6 of these countries, turned to restricting visitations across the board for all of these countries. The difference was that there were some countries that had a bit more flexibility and understood, yes, we need to keep visitors out, but we can't prevent people from seeing their loved one. And so they would try, and keeping in mind that at the time, nobody knew what COVID-19 was. Nobody knew how it spread, right? Like this is there during the time when we're washing our groceries and our cereal boxes and all of these kinds of things. So nobody knew. And so although we were very hypervigilant, and certainly other countries and other long-term care sectors in these countries were as well, they did have an understanding of the importance of the role of these family caregivers and the role that they played in the lives of these residents. And other countries were much better at honoring this relationship than we were. And so, Sweden had, although they also restricted visitations, they did allow, some more auxiliary staff to still come in. People were still able to, get their hair done, for example, or see spiritual care, for example. So residents weren't on their own. Other countries also had, they were quicker to put in place some different innovations and creative ways to sort of maintain these relationships while maintaining distance and under the umbrella of safety. But certainly I feel like other countries were a bit more open to that. And I'm not as pessimistic as Vivian. I feel like this entire experience and our research, although it was focused on family caregivers and the trauma that they experienced, staff, administrators, they also went through a hard time too. And I think we're all learning about how to not do this again. Where I am not as optimistic, it's more on the policy level. I do hope that there's more movement there. But I think at a more individual level, at a home level, I think people are more aware now. And my hope is that we're not going to see the same devastation and, to be frank, assault on long-term care homes as we just saw. Vivian, do you have?
Yeah, I mean, from the home level, of course, there were examples, and there'd be times when I'd see cases, in the media, like I think it was Kensington that was hiring family members because they said, okay, yeah, we can't deem them essential. Well, we're going to hire them, and they're going to work on the whole floor where their loved one is, but they're also going to have to do some stuff to help out other residents, which they were totally fine with. It, like things like that. Like, do you know how many families would have in a second? They do this work for free anyway. Hire them, sure. Let them get in there and help. And if they want to, and they can, and they would have, like ideas like that, you could have been, operating within the confines of stupid policies at the provincial level. Some homes were doing that. And then, of course, you hear about homes more broadly that just, they handle dementia care more better. So the butterfly models that you tend to see in the municipal homes here in Toronto that were really famous. Moira Walsh did a huge, documentary, little story and investigative piece into those homes, and they've done a great job with really changing how we actually, work and live in those facilities. Making it less clinical, making it more family life. And then there's another example of a home, outside of Ottawa that just, they call it the Golden Girls home, where they just, house 16 women. And it's like literally like just a home, a small home, not this big warehouse that feels like a home. It's all one floor. Everyone has, access to the outdoors. And that was another important thing, right? One of the things that we found in our research was, let me tell you, loved ones who had residents that had first floor rooms, particularly that they could walk up and see their loved one at the room. That was prime real estate. Like, you would never believe what a hot commodity that was, and how upsetting it was for other, like we saw stories where you saw this in the news, people that would drive pickup trucks, put a huge ladder against the wall and climb up to a third floor window to try to see their loved one. Like, this insanity was happening. And then you realize how we really got to stop having these giant multi-floor warehouses, that we need all one floor community style, housing style, ideally smaller units like the Denmark model, where you have like 8 to 10 individuals in a house, right? And you have workers that live, effectively, on certain time shifts, but live in that house too, and do like they're with the residents all the time. It's just not a constant influx, a revolving door of workers, of hundreds of workers, if you're lucky. But really accounting for the fact that make them more home-like. Look at the physical infrastructure of these homes, during a pandemic, operate without the confines, like go color outside the stupid lines, right? Do what you have to do. Be creative, be flexible, but exercise some empathy and some humanity, and do the right thing. The amount of times that these poor family members we told, well, it's what the government said we have to do. Like we can't do anything. Yeah, you can. Yeah, you can. Where is the exercise of judgment to see a bad rule? And, I'm not a rule breaker, but when there's a stupid rule, I'll be the first one to break it. Because, at some point, you need to take that, independence and that power to say, no. Like, we need to exercise better judgment here, because clearly the people in charge, whoever it is, are not exercising good judgment here. And we have a lot of evidence for how the policies to lock these families out did not save lives. It didn't stop the outbreaks. So what was the point of it? Other than literally confining these residents and traumatizing their family members, who had to watch the news and see the terrible things that were happening from afar, knowing that they could help, but weren't allowed in. I mean, I share the anger of these family members, if you can't tell, just a little bit.
And that's actually being echoed in the comments. We're getting comments like, I feel so helpless, like we just cannot make the changes needed. It's incredibly frustrating. And then also to thank you for the work that you're doing, and that it is important to hear the stories. And I think the quotes that you shared really, really highlight those, or demonstrate and bring to life those impacts. On the policy side, there's a couple questions that we've got coming in. First is sort of in terms of dissemination to decision makers. Are your findings and research going to be forwarded to the federal or provincial governments?
Well, as soon as we're in this fun process of peer review, which takes a long time, but we've got them coming soon. So trust me, we will be sending those everywhere we need to. And I have contacts through my own advocacy. Those are going to be going out, but not for nothing. This research, and I'm so happy that Dr. Chu reached out to me to want to collaborate because, not informally, but I started my advocacy, which kind of really launched into this research because, Dr. Chu was like, I'm seeing you on the news. We need to study this. You want to do this? And I'm like, yes, I want to do this with you because I was too busy just trying to fight, frankly, politicians to do the right thing. So I have been trying to put these, because the results we found in our research merely corroborated what we were seeing in the larger community and in the media. I mean, what you saw happen in the first year was really what we were hearing, just various iterations, different homes, slightly different traumatic experiences. But I mean, what you saw in the media, what you saw in these news stories, and what you heard people, advocates that were in the media criticizing this government, I mean, it's all reiterated and just corroborated by our research. So there's not a lot of news per se. We have obviously suggestions. We hope that people really take home how traumatic this was and really work towards a trauma-centered approach to dealing with the harm that occurred during this pandemic to help really appreciate how important these essential family caregivers are. But I mean, I feel like I've been yelling this for 2 years now. So I'll keep yelling as much as I need to, but I feel like people should know just how bad this was. I mean, maybe we need to yell a little louder, and I'm happy to do that. But if other people have ideas, I'm all ears. I'll listen. Right? Tell me where I need to shout to get this message out there more, and I'll do it. We'll do it.
We're definitely going to disseminate as widely as we possibly can.
Great. Yes, I would definitely hope so. A related question is to the point around national standards. And should long-term care homes have federally enforced minimum goals or standards to be met for each resident? So, the Bill of Rights is one thing, is important, but what about goals or standards related to care, hours of care, or type, staffing mixes, et cetera?
Oh yeah, I mean, I've been very public about my opinions there, and I was disappointed that in the recent care standards document, draft standards, there wasn't an actual hour allotted. It was, and this is one of my criticisms of that recent document, is that it was so vague. Great people working on it, brilliant people, but it was too vague to actually enforce at the home level. And I'm a practical woman. I want to see very clear, non-negotiable language. You have to provide 5 hours of daily care per resident per day. None of this average nonsense of 4 hours across the homes that we're seeing in Ontario. I want a minimum. Frankly, the experts say should be between 5 to 7 now. So that 4 figure that our government has chomped at the bit on was frankly from decade-old research that I actually was a part of. So it's completely outdated. And it should be somewhere between 5 to 7. So things like that, that's what I want to see. I want to see clear, non-negotiable standards that are around, if you do this, if you don't do this, provide, 5 hours of minimum care per resident per day. That's it. You get hit with, $100,000 penalty. You get personally charged. I want to see criminal penalties against these owners and operators for not holding up their end of the bargain. I want very clear, tangible standards. And that, that's my hope. That is what I want. And I think we absolutely need, because anything vague or ambiguous is just never going to be enforceable. I want something enforceable and clear and very easily understood by everyone involved.
Great. Also, perhaps aligned with this, enforcement, actual consequences for action or omission. What are your thoughts about what's happening to what we're hearing about some essential caregivers who have been whistleblowing, as commenters pointing out? So raising very real concerns. It's more than just a personality conflict, but they're essentially being banned from their loved one through trespass orders.
Oh, yeah.
What is this possible? Why is this happening?
Sickening.
And what do we do differently?
Oh, this fills me with inordinate rage when I hear these stories. And I know the woman who was hit with one of these first trespass orders, and she actually worked with Joel Harden, an NDP MPP, to table Vula's law, which was a bid to try to prevent this from ever happening again. But of course, our PC government did not pass this into law yet. And I presume it probably won't be passed into law, just like our More Than a Visitor Act wasn't passed into law, because heaven forbid that actually protects the people that are supposed to be protected in these facilities and not bad actors who maybe want to abuse the rights and unilaterally create their own and get away with things, quite frankly. So I think it's abhorrent. I think it's disgusting. I absolutely think that we need to keep pushing our elected officials to actually make things like Vula's law and make it so that they can't do this. Like, you cannot do this. It's one thing if you have a threatening family member, but we're talking about these are just people who are whistleblowing and are being penalized. And we heard that all throughout our research. It wasn't as aggressive as trespass orders with our participants, but it was, oh, we're not going to answer the phone when you call. Oh, your visit was canceled. Sorry. So there were clear penalties that would come with whistleblowing. And I hear from families more than anything in my advocacy, they're terrified to speak up because they're worried of the consequences. And they have very real reasons to be afraid. And you usually see the families only speak up once their loved one passes. And that's the terrifying reality, that you feel like your loved ones are captive in these facilities and they're at the whim of, these providers. And that's a terrible way to feel. It's very akin to incarceration, to feeling like your loved one is in a prison. And it shouldn't be like this. What is it? The crime of aging, the crime of having a disability, that all your rights and your freedoms can just get unilaterally revoked overnight. I don't know what to say as to, why this is happening, other than get lawyers, fight these bad actors. I'll help you get lawyers. I mean, it's just, unfortunately, we have elected officials who aren't doing what they should be doing to better protect these residents and these family members. And it now is on the families to protect themselves. And unfortunately, often through the civil court system, which is, you shouldn't have to go through that. But this is what many families have to go through to get some sort of accountability or justice.
Dr. Chu, is there anything you wanted to add to that?
No, I think she did a pretty good job.
Well, so there's obviously been a catastrophic breakdown of relationships. Families don't trust the system, or they don't trust the home operators. There's, as you pointed, the trauma of the experience, and also just even what's happened outside of long-term care in the last 2 years. The deaths, the murders by police of Black Americans, the unearthing of or the findings of residential school graves in Canada. There is a lot of trauma that's affected people, some groups of peoples more than others. But if we want to achieve better and we want to rebuild collaborative relationships between staff and families, how do we do that?
I mean, I know, one of the ways is really to focus on a trauma-centered approach going forward, right? And I really think that when you respect the trauma, and I one of the courses I teach is restorative justice, so I think that we have a lot of opportunity to really involve. And the whole point about restorative justice is making amends, taking accountability, owning what you did, and making a concerted effort to involve all of the people harmed directly and indirectly, be it, in this case, the residents, the family members, the workers, the owner operators. You have to bring them all together, and you have to heal that harm together. There, without actually empowering these people who have been absolutely disempowered during COVID-19. I don't know how we move forward without a proper and real apologies and a plan to move forward and address the harm sufficiently. I don't see how we move forward in any real productive way. I just think we're going to be replicating very deep-seated antagonisms and mistrust that have obviously been put in place during COVID for good reason.
And I think, Sam, you picked up on a really good point around just general mistrust that I think people are having with the government in general, more broadly speaking. And we're seeing this with, misinformation, the way that the COVID pandemic was handled, racial inequities, and then also with long-term care. And, in our presentation, we talked about the family caregivers having this trauma, but they are going to age themselves. They're going to, and we've heard that they've said that they have PTSD from this experience. They have PTSD. They're never going to trust long-term care ever. And they are like deeply, deeply traumatized. And so when we're thinking about how do we rebuild trust, not just on an individual level, but as a system and as a society, I think there's so much work to be done there. I'm not sure if there's one singular thing that can start to do that, but I think if we are going to start somewhere, I think that has to start, first of all, with acknowledgement, with validation of feelings, and then with empowering all of the players that have been impacted. And most importantly, I think for marginalized groups like women, like caregivers who have just gone unheard in this pandemic, I think having empowerment and having those structures to help support them would probably go pretty far as a starting point anyways.
Mm-hmm. And it's going to be a journey. There isn't going to be a stopping point.
Exactly.
I imagine that the impacts of the collective trauma on the people on the group that you've worked with and the other caregivers, residents, families across all long-term care and congregate living settings it takes time. And I don't think we'll ever be done the healing as a group. So in terms of, supporting the healing, supporting quality improvement, basically the what next and how to make it better, and you actually touched on family council. So this is a question I'm really interested in, is what role does a family council play in the advocacy to improve the quality of life, address concerns, I'd add start the healing, and what tips do you have for those family council leaders who are like, this is a problem, we need to do better?
I mean, I know through my advocacy, when I've, kind of teamed up with some of the family councils that I've met, I mean, just collaborating and learning from some of the really well organized and well, the really cohesive family councils, because it's always a journey. You got to start. And then sometimes, you hear horror stories about some family councils being potentially co-opted by the home, and then you have issues there. So it's really, it is a complex issue, but there's no doubt that it can be, and it should be used, and it can be used and has been used for good, more than potential evil, let's say. So I think that, really helping to bring these family members together who are first operating really successful family councils, sharing tips, sharing strategies. Like we should be having huge family conferences like this and having families get together and share tips and share strategies. I mean, one of the most, just speaking from my advocacy side, one of the things that I would hear from family members the most the advocacy helped them just share tips and meet people like them, and they could share strategies, and they felt like they had that support system, right? So, I mean, I think that goes a long way to just feeling like it's not us versus them necessarily, because we felt a lot of that, and we heard that a lot in our research, where you feel more powerful if you are with a group of family members and residents, loved ones, who can really team up together and kind of build that power and become empowered through that group. So, it can go a long way to really petitioning the homes to improve the quality of life and to make sure you have rights being followed, and to maybe actually force these homes and really keep hitting it home that maybe you should listen to the long-term care commissioners as an example and start providing counseling to the people that have been traumatized and remain traumatized by the 2 years of terrible policies and prolonged confinement and separation. How about that as a start? Right? I mean, there are tangible things you can do that have already been suggested and put out there by many experts and advocates in the area. We need to push for this stuff to happen, to really start the process of healing. But I haven't seen a lot of that yet. I still feel like these families are still in it. They're still in the war. They're still in the trenches. They're still dealing with this. And they don't have time to look back and go, how do we change the system? And it's also tough to put that onus on them, right? Like, it should be the government. This is why I've been fighting to have standards and to have the government do the right thing, do their job, and make this a system level change, instead of having these poor families who are already tired and stressed out enough having to fight for change. So there is strength in family councils, but I also want the government to do more.
Yeah, ideally, families shouldn't have to fight that battle. They should be able to be spouses, children, and reform those or change the relationships away from advocates or primary caregivers by being able to really trust the people who are caring for their loved one. I will say that to the audience, I promise that comment by Vivian wasn't a plant, but we are holding a family council conference in June. Stay tuned.
Yay! I swear, I didn't know it wasn't a plant.
Our third virtual conference with a bunch of events, so stay tuned for that. But maybe following up on that, I think that another really good point is around implementation of projects and initiatives that families and caregivers, some have done quite successfully. So did you hear any stories of strategies where councils or caregivers collaborated with the home and staff to implement things like the Partner in Care Pledge or the Essential Family Caregiver ID and training program that it was being supported by Ontario Caregiver Organization, or something similar that was an overt recognition of caregivers?
Our participants did not, weren't directly involved in those experiences, but I mean, you would hear these situations where they were involved in the broader community of long-term care. And of course, those are great. Like, we have caregiver organizations that can and often are partnering with family members to try to, like the Ontario Caregiver Coalition. So there are coalitions, there are family councils, there are groups that can actually suggest these good ideas. Did we encounter them in the study per se? No. Well, I don't think we did. Did we, Dr. Chu? We didn't, right? No, there wasn't any. No. So we didn't hear those per se in our study, but I mean, of course they do happen. I do hear things, but they're far and few between, from at least what I hear. I mean, maybe they're happening more and they're just being kept, more discreet. But the cases of like the Kensingtons and the hiring families and doing things like that were the anomaly that at least I experienced during COVID from my outreach with families.
And that speaks to the inequity between the homes. That's something that came up in our research as well, that depending on what home you were in, you were treated very differently. Your loved one was treated really differently. Your resources were different. And I think that speaks to that as well, because if you're in a home where, you have leadership and staff that are willing to empower and, be in this collaborative team with families, versus others that aren't. I mean, I think there's a real discrepancy there, and that's not fair. I mean, that's problematic.
And Dr. Chu, I think that's actually, your point around leadership is a really important one. And that's being echoed and reflected in the YouTube chat as well, with one person saying, I was told by the ED, the fourth one in a year, of my aunt's long-term care home, and I'm chairperson of the family council, that she has, quote, never seen so many angry family members. End quote. Are you kidding me? I told her she needs to earn that back. And so there are some leaders who, throughout the pandemic, have been innovated, who have maybe pushed the boundaries a little bit and really committed to open communication, authentic engagement, and doing whatever they can. But there are definitely those that haven't. And what, maybe in one sentence or two, what would be your message to those who at this point still don't really get it? What would you want to say directly to them?
Oh man.
To leaders,
to the providers,
who
to the
are
providers,
in positions who don't get it.
Leaders, yeah, who just.
What I would say to them? Oh, you don't want to hear what I would say to them. But
there would be some expletives.
My first word is
bleep
quit.
out. Bleep everything out.
My first word is quit. If you're in this position and you have a responsibility to take care of people who are depending on you and to take care of family members who are there to love their loved ones in these homes, who have no choice but to put their loved ones in these homes. If you do not understand the importance of that relationship and you don't understand what privilege you have to provide care for such a large number of people, by now you need to quit.
Leave. Yeah, I mean, exactly. And we would hear that a lot in the research too, that I think fundamentally the families that were the least traumatized, because it was traumatic bar none being separated, but at least for the families that knew that they were part of homes that were resourcing properly, that were following proper infection prevention and control, that were actually leaving the lines of communication open. I mean, that went a long way to mediating and reducing the stress and the trauma than those homes who were often repeated bad actors, constant outbreaks, high mortality, who were clearly just messing up over and over and never learning, high staff attrition, not enough staff on site, revolving door. I mean, it made a difference, right? So, and we would see that, we didn't necessarily draw the difference between for-profit and not-for-profit in our study as a theme, but it was clear that a lot of the municipal home families were definitely better resourced and felt that the communication was better. There were people actually in charge of the communication versus trying to just get the nurses station and calling that as much as you could. There were actually people tasked with communicating with families. There were plans, and progress reports emailed to families frequently, things like this, which went a long way and which showed that some homes were just doing more to keep the lines of communication open and to show that they were actually trying to, do their job properly and keep the residents safe. Because that's fundamentally all that these families wanted, was to know that their loved one was being safe and well cared for in their absence. And unfortunately, and we know this from everything we learned, in many homes, that just wasn't the case. And that's what obviously would contribute to a more traumatic experience for some families over others. But it was traumatic bar none, but mediated by the success and efficacy of the home in managing outbreaks, in managing communication, and in really dealing with family members.
Yeah, what we heard time and time again, and a recommendation we were trying to make, is have one staff person, or to be your contact person.
I know!
Yeah.
Have someone answer the phone!
Yeah.
That was the most frustrating part.
Be proactive, communicate openly about here's what's happening. We, put families' minds at ease. We have sufficient personal protective equipment for the week. We're good on that. Just let people know so they're not guessing, because it's pretty human nature. If you don't hear, you expect the worst.
Yeah. Well, and I think the worst part too is that these family members would have done anything. If you told them if you were just transparent and said, you know what, we're having an issue with securing PPE, if I was one of these families, I would have literally been doing anything and everything to try to get PPE. And many of these families were contributing, were volunteering, were getting resources, getting iPads, doing whatever they could do to help. So like you have this support system who wants to help make your job better and help you do a better job at helping these residents. But, you know, some homes just completely did not miss that opportunity to involve these families and to actually have them as part of the team, which they should have always been part of the team, right? So, you know, these kinds of things, like just be straight with people, be honest, be transparent. And if there is an opportunity and maybe you're flailing a bit and you're having trouble securing whatever rapid tests or PPE, be honest, and maybe the families can help, right? Like you never know where you're going to get that source of support and assistance. And God knows, some family members could be PPE producers, IPAC producers, like reach out. You never know where you can get help from. And the fact that they were just kind of shutting the door and just kind of closing the line of communication, which seemed to be the pattern, was just such a missed opportunity and just bad business, just bad operating practice of providers who just didn't want to deal with families. They just saw them as a nuisance and were just, and a lot of it was, and I kind of err on the side of the families with this one, that they didn't want them to see how bad things were in some of these homes. They didn't want them in there. They didn't want them whistleblowing even further. And they deliberately kept them out for as long as they could. And I tend to think that, some of these providers were happy that they had that terrible provincial guidance that locked them out.
So we're coming to the end of our time, but there's still a few questions that I want an opportunity to discuss. So one person is saying those descriptions of the experiences of the family caregivers make me believe that before the pandemic, things were not well. So is this true? Or do you think it was the pandemic that really brought out that trauma and uncompassionate treatment?
I mean, long-term care was a mess before the pandemic. There's no question about it. I mean, consistent understaffing, underinvestment. I mean, this is across the board. But then again, I mean, we never experienced something like this. This was completely novel. Locking out family members, this level of prolonged confinement and separation had never happened before. So that level of trauma and experience was completely new. And of course, the nature of the illness and different provinces' mishandling of the pandemic, let's say, made those long-term care experiences worse by having, frankly, stupid policies that would contribute to more illness. Because when you had more illness, obviously you had more death at the resident level, but then you also had massive staff attrition, which we saw most recently with Omicron, which we knew was going to happen. Because the government didn't act early enough when we were getting warnings from the international community, our government in Ontario at least, and provide the safeguards that we needed in early December to mitigate some of those unprecedented staffing losses. I mean, we had upwards of 5,000 long-term care staff off, sick with COVID in like a 1 week period. I mean, who's in there replacing that care? Thankfully, we had essential caregivers that could go in, but it was only, one, maybe two caregivers that could go in. So is that going to cover for the 5,000 skilled workers that are off, that we could have mitigated those illnesses if we had done things at a system level that we didn't do? Yeah. I mean, so sure, COVID, long-term care was a mess before COVID, but COVID brought a whole new set of challenges and really show you just how bad it can get.
Yeah, COVID definitely exacerbated a lot of the long-standing issues in long-term care, like short staffing, like poor resources, as Vivian has talked about. But I think there was still a respect for the relationship of family caregivers and the role that they played. I think they were still leveraged because they knew that they needed family caregivers to make up that service gap that was expected and what could be provided. But once we had those restrictions and family members were unable to get into these homes, then that gap became very, very apparent. And then the relationship between the families and the residents and the staff started to deteriorate. And so we also saw that in the quick survey that we did with our participants as well, where, the majority of them were fine and happy with the care that was being provided before the pandemic. And it was during and after, it just skyrocketed up to almost 70% of people we spoke to in our sample was unhappy. So.
And I think that's very much echoed in what we're hearing in the chat. Before I get to the last couple of questions, and they lead so well from what's being said, participants saying, or attendees saying, my grandmother passed during July 2020 of COVID. We were only allowed to say goodbye through the window, and she had dementia.
Sorry.
Another person, my father has had an iPad throughout all of COVID, but he did not know how to use it. Lack of staff support for it. The home would not assist, so any communication was limited to a phone call because he's on the 8th floor.
Yep.
My father's now suffering from severe depression. During the lockdowns, he spoke numerous times about ending his life.
Yep. We heard this.
Yeah, staff being told to keep residents in their hallways of the rooms when outbreaks were bad. And this was folks who were living with dementia who couldn't understand what was happening to them.
Yep.
I'm a pet person, so this one really breaks my heart. We had to remove our father's dog, his best friend of 10 years, because there's no way for the dog to get out. It's just a friend, a creature, a family member who brings so much joy to a person's life. And it really does speak to the trauma. And so a question for you as researchers: what strategies did you find helpful to deal with or process the emotions that you experienced as you were doing your interviews, your data analysis, and reading the stories that were shared with you?
Oh, I know what I did. Well, apart from crying a lot, I turned that rage into my public advocacy. That's what I did. I made a lot of politicians very uncomfortable, and that gave me significant joy, because that's something small I could do for these family members. So that was my way of projecting a lot of that just massive violation of common decency and fundamental right and wrong. And just, I projected it in my advocacy. That's what I did. So, yeah.
I think collaborating, talking to others, my grandfather was in long-term care, passed away in long-term care. This was before the pandemic. But, I think the problems that existed in long-term care were just highlighted throughout the pandemic. And, I think we both sort of tried to do our part. And so I do it during using research as an avenue to try to understand and illuminate what are some of these big problems, how we can move forward, and working with advocates like Vivian, drawing more attention to this area. And then I think on a personal level, I think we've just talk a lot, drink, maybe cry.
Yeah. Eat a lot of chocolate. I talk to a lot of, family caregivers too. So through not only the research, but, just the advocacy. And keep in mind, me and Charlene were both family caregivers, right? We were both essential family caregivers. Like I was to my grandmother in long-term care. My grandmother passed 2 weeks before the first case of COVID hit here in long-term care. And that's why I started advocating, because I knew how important, I was there 4 or 5 times a week, sometimes 6, 7. I knew how much time I was putting in as an unpaid caregiver because of the flaws in the system. And I just thought, oh my God, if she was alive right now and they tried to keep me out, and I just felt such immense anger and frustration for these families who I knew had an integral role in this system, having just lived that role and dealing with my own trauma of losing her in ways I won't talk about because I'll just start crying. But I understand where these families are coming from. First and foremost, I consider myself an essential family caregiver, right? And I've always been, I see myself as that first and foremost. And I identify with these families. And that's why, it was important for me to start speaking up when weeks turned into months. And then there was no end in sight. And it felt like nobody was saying anything about how terrible this was. And I just have a big mouth. And I started using it. Yeah.
All right. So this is going to be our last question. I saved it for last before we wrap up. This is like your presentation, I want to end on, okay, what do we do next? What has to change? So we know, and you alluded to this in staffing turnover, and the requirement really for it to be at the home and sector level to make changes that support the family caregiver and resident experiences. There's a lot of transition. What key messages would you want to share with people who are new to long-term care leadership? Not those who perhaps are on their way out, but those new people who are coming in and saying, I'm going to do better. What do you want to say to them?
Watch this talk. Let's have a conversation. Let's sit down with some family members, right? I want you to hear what they went through. I want you to hear the words come out of their mouth and see the pain that this caused them. That's what I want them to see. I don't think, I can throw a paper at them and then they might read it, but like, it's always most powerful when you hear it from the family members. And that's, why, at least through my advocacy, I was behind the scenes for the first 6 months of my advocacy. I didn't do any interviews. What I saw with my job, my volunteer side gig of advocacy, I'm not paid for any of this, by the way, just so people know this. This was, on the side of my full-time job, where I was just literally, families would reach out to me and I would just connect them with media and get their stories out there, because nothing is more powerful than hearing from the families themselves. So yeah, while we're happy to share our research, it's always best to hear it from the people impacted directly. So I would love new providers to just meet with their family members, even the first thing they should do, you start this job, have like a town hall, meet with all the families, hear what they went through, hear what they need going forward. You could start on a really good foot that way, right? Start off by actually communicating and listening. And I think that has to be the first real perspective, the first stage. And I did, you'd think I wouldn't, because I was very on the side of essential caregivers and residents during this pandemic. And it kind of seemed like I might've been against the providers, but I still had providers reach out to me. I even had some for-profit CEOs reach out to me and listen, I will work with anyone and I will talk to anyone who actually wants to help and seems, open to suggestions. So just reach out and talk and listen to the people that were impacted. That's the immediate advice I would give.
Building
Charlene?
on that, this morning I taught my graduate class. So, these are nurses who, some of them are in long-term care and they want to be leaders and advanced practice nurses in their various fields and areas. And even to my undergrads, I really encourage them to be creative and to not only be empathetic to their patients and to their staff and to their colleagues, but really start thinking outside of the box. Be aware of your resources. How do we leverage relationships? I think that's really important. And trying to be strategic. Long-term care, especially, and this extends more broadly to our entire healthcare system. But we don't have an endless amount of resources. So you have to take what you have, leverage that, and really prop up what works for patients and residents. And often that's going to be the wife who's coming in and feeding every day. That's going to be the family member that's coming in and helping the resident get dressed. Like, that's going to be the singular most important thing in their lives. So how do you as a leader enforce that and help foster those relationships and those collaborations? So empathy, creativity, some innovation, I would always advocate for that, in addition to everything that Vivian just said. So thank you.
Absolutely. Well, yes, creativity, thinking outside the box, passion, human-centered connection, being trauma-informed, looking at healing and opportunity. That's come through loud and clear this afternoon. And I'll echo what everyone is saying in the chat to thank you for your passion and your work on this to really elevate the stories of essential family caregivers and to to share this with us. So Doctors Charlene Chu and Dr. Vivian Stamatopoulos, thank you so much for your time. And we are going to wrap up this afternoon's session. Thank you so much.
Thank you.
Thank
What
you,
a
everyone.
wonderful session full of passion and evidence, inspiration and hope, but also a really stark and frank reality looking at the trauma, the effect, and frankly, I think it's going to be the beginning of really long-term results out of this, whether they be personal results and family trauma or hopefully some changes that can come out of it. We do have a little bit of hope for the future. National standards are being released in November. We've just closed the review process, but you can probably still get in there at HSO and CSA for looking at national standards. Not that they will solve everything, but as Vivian says, a step in the right direction. This incredible session is going to be hard to follow, but I can tell you it's going to be an extraordinary next session on April the 28th from about 1 to 4. We are going to have a conversation with author Michelle Good, with Michael Tamblin, the CEO of Rakuten Kobo, helping to interview her. Just a quick note, her book, Five Little Indians, was the debut novel of her. You may remember that she's a Cree writer and former lawyer, and it's the second book that she's done. It won Canada Reads in 2021. It was the best-selling book in 2020 and won the Governor General's Literary Award for Fiction. She is a member of the Red Pheasant Cree Nation in Saskatchewan, and she holds a Master of Fine Arts plus a law degree from the University of British Columbia. So in case you were thinking that, she wasn't busy, she certainly did a lot before she started writing. And this conversation is going to focus on the intersection of aging, creativity, indigeneity, and storytelling. And I am personally really excited about it. But I have the also great honor of thanking our 3 speakers today. Each of them brought both lived experience, evidence, passion, and our work at the front lines into this incredibly enlightening conversation. So it's my great pleasure to thank each one of you and to sign off for today. So we'll see you on April the 28th for a conversation with Michelle Good, and all of you have a great rest of your day.